theme, partly because we know that if you're physically disabled, it's difficult to get out, but long COVID isn't just, it's not really a mobility problem in the sense of musculoskeletally, you can still walk about. It's not that you're paralyzed or something like that, but it's an energy limiting condition, which means that even socializing drains your energy and makes you ill. It causes post-exertional malaise. So you lose contact with your friends, you lose contact with your support networks because you just don't have the energy to engage with them. And we know that people with disability and learning difficulties can't access healthcare as easily as others. And a lot of people with long COVID have cognitive difficulties that makes it really difficult to keep track of it's like a full-time job keeping up with your healthcare. And it's also really difficult for that reason as well. Next slide, please. This is what we hear a lot. You're the wrong age. There's a right age to have long COVID and it's middle-aged. If you're at the end of those spectrums, then you have to fight back against stereotypes. So young people are told, oh, you're too young to be ill. Young people don't get ill. You just have to go out and enjoy yourself. Take your mind off it. That'll sort you out. And seniors are told, well, you're not as young as you used to be. Even though the day before they had COVID, they were perfectly able. They were out on their bike, they were gardening, they were volunteering or working. And then after COVID, they're disabled, but they're told somehow they should just expect that because of the age that they are. Next slide, please. Healthcare poverty is an issue. We have an NHS. However, we know that the NHS isn't always functioning very well in the first place with waiting lists and so on. But with long COVID, it's different because the services are just not there yet. Services exist, but they're not actually offering medicine at the moment. They're offering therapies, which have a very limited ability to get to the underlying causes of long COVID and actually take away your symptoms. And a lot of people are spending money on things like hyperbaric oxygen therapy. They're going abroad for treatment. And that's very, very expensive. And if you can't afford that, you can't afford that. And then you're stuck. People are also trying various remedies, supplements, proteolytic enzymes, and other things that you can buy over the counter or you can buy online. And again, they're actually quite expensive. Some of them are very effective, but they're expensive. So if you're poor, you're left out of that ability to take care of your healthcare. Social underprivilege is also a problem. With long COVID, you end up seeing doctor after doctor, you get sent to service after service. That's a lot of time off work to go to appointments. If you need all your annual leave to cover childcare and school holidays, and you don't have a very sympathetic employer, or you need all your work hours to make ends meet, it's really difficult to get time off to go to all those appointments. Next slide, please. Politicization is something that I don't see talked about a lot, but it's a really big issue. COVID became politicized, more so in the USA than here, but also here. And there's a bit of rewriting of history going on now that we didn't really need lockdowns and COVID wasn't that bad. So if your family and friends and community are moving on with COVID and don't care about it anymore, it's really difficult for you to still be there saying, yeah, but I need to protect myself because I can't get reinfected. Reinfected really badly affects me. I still want to wear a mask. I still want you to test. Masking is viewed as a radical and provocative act in some communities. And it even gets to the point of friends and family who don't even believe long COVID really exists. So that family member then gets cast as a bit of a drama queen, attention seeker, who's always going on about their COVID and everybody else has moved on from it. So this leads to family breakdown. And this goes from like, oh, I just don't talk to my brother. I go to family events, but I just avoid them. I just can't. Or even I used to be really close to my sister, but I just can't talk to her anymore. So it's causing real fracture within people's support structures. What were their support structures? And we see people saying things like, I found out who my real friends were. And the people they thought were their friends are just not there for them anymore. Next slide, please. And I want to talk about a couple of case studies now. And the idea of long COVID not being believed, and this is quite prevalent in society. The idea that this is a psychologically induced illness and it's not really a physical illness is prevalent in healthcare and in general society. And the ultimate end point of that is what happened to John. So he was a perfectly happy middle-aged professional married man with young children, got COVID in summer 22, and has suffered extreme pain thereafter. He went to doctors, they did tests. This is a typical story. They do tests, they find nothing wrong, and then they say, well, you can't be in pain then. But he said, no, I'm in pain. And he's trying to do things to cope with the pain. He's continuing to seek healthcare. The family, believing the doctors, and why wouldn't they, now see that as a mental health problem. So his family actually called in a mental health team who had him sectioned. So he was detained in a mental health unit for 40 days. And he was pressured to take antipsychotics, but he refused because he knew he wasn't psychotic. And he used his privilege, because he's a professional man, to arrange for another trust to do a review and to get the actual physical scans that he was demanding, which did show some pathology. But this whole process has caused so much conflict within his family that he's now going through a divorce and he's actually banned from seeing his children. He's not allowed to set foot on school premises. Next slide, please.
1 minute, Margaret.
Okay, thanks. So this is a tale of two mothers, Sonia and Emma, who are both educated professionals and trying to navigate services for their children who has long COVID. They also have long COVID. Next slide, please. So Sonia's reaction to this is to literally keep her head down. She's even started questioning herself, like, am I really brainwashing my child? Sometimes she's worried she'll get accused of making it up. Next slide, please. Emma, on the other hand, has come out all guns blazing. Woe betide the doctor who tries to gaslight her. Now, the difference, they have the same social background, but the difference is that Emma has been here before. Emma has had in the past a contested illness, and she knows the value of the army she talks about here is the Patient Advocate Society. She knows that she has them behind her to support her. Next slide, please. And you might ask yourself, why does Sonia literally keep her head down? Why does she not fight back? But this is a really common reaction of the powerless to the powerful when they know the powerful can do them harm. And the harm here is this is actually happening in the UK at the moment. Children are under threat of removal from families. They don't go to school. The children can't go to school because they're ill. The school calls in social services who call in healthcare professionals. The healthcare professional don't know anything about long COVID and say, oh, but COVID doesn't really affect children, so they must be fabricating this illness. Then the social services put pressure on the parents, and if they don't send the child to school, and they don't because they know it will harm their child, they're threatened with removal. So the double injustice, the children are being taken away from caring parents and will be sent to someone who will not know how to care for them. So final slide, please. Our peer support groups, can I have the next slide, please? Peer support groups do not offer a cure. We do not really offer any physical help. What we offer is this safe space, and this is from one of our members. Long COVID support group is my safe place to go. I don't post how I am anywhere else. I've learned over the last few years that nobody outside this group wants to know. I avoid bad comments by coming home to here. So I think that's my time up now, Nisreen.
Thank you very much, Margaret. And if you can stay with us for the question and answer at 9:50, that'll be great. If you can, thank you. I'll quickly hand over now to Dr. Nina Smith, who is
presenting findings from the High Cove.
It's recorded. I think we're fine to go.
I'm going to be presenting findings from the High Cove, hearing from the Unheard Voices of Long COVID study. This is an NIHR funded project and is collaborative between University of Westminster, Keele University, Queen Mary and University of Southampton. As you can see on the screen, all the co-authors are listed. The aim of the study is to explore the lived experiences of long COVID in racially and ethnically minoritized communities, their healthcare experiences and the extent to which their care matches their needs, and how their support needs can be better addressed. There's three aspects to this study. There's the qualitative study where we interviewed 31 participants about their experiences of long COVID. There's the stakeholder workshops we conducted and the co-creation of artwork. And we also had an active patient advisory group advising us on each stage of the research. We've conducted 31 interviews with people from a wide range of socio-economic backgrounds and long COVID experiences. Table shows the demographic profile of participants. As you can see, we've got participants in different age groups. We've got an equal number of males and females, and the ethnic minority groups include people from Arabic, South Asian, Black or mixed background. We've got participants from a range of occupational backgrounds and socioeconomic status. And we've got participants with a range of long COVID experiences, some with a clinical diagnosis of long COVID, others self-report long COVID, and some participants didn't know whether their symptoms were long COVID. Some accessed healthcare for their long COVID symptoms. About half of the participants had a pre-existing health condition prior to their COVID infection, and the COVID infection could have been in 2022, 2021, 2020, and some as recent as 2023. Participants describe primary care services as a gateway to receiving support, such as clinical investigations, medication, referrals to specialist care. However, most participants reported challenging accessing this type of care, and when they did access care, they experienced challenging interactions with healthcare professionals, dismissive attitudes, gaslighting, hostility and lack of understanding or interest. Only a few people reported good care or support. Validation and acknowledgement are needed for people living with long COVID. The two examples of the quotes on the screen show contrasting care experiences by participants. The first quote talks about the power that healthcare professionals yield over them and the lack of support they had, whereas the second quote talks about the positive experience somebody received and how everybody deserves care like this. Not everybody accessed healthcare support. Some didn't want to bother healthcare professionals with their symptoms, despite their symptoms having an impact on their lives, and they were clearly causing a lot of suffering for them. Some people didn't want to associate COVID-19 with the symptoms they were experiencing, and some other people needed validation from others to say it's okay to access healthcare for these symptoms. Others feared discrimination and stigma or didn't trust healthcare professionals due to their past experiences. Getting to specialist long COVID clinics was difficult. People had to advocate for this. They had to advocate for their referral from their primary care health provider. When they did get to the referral, there was long waiting list, and many people had to follow up this care, and they had to ensure that their appointment came through. Participants felt that services that they received from the long COVID clinic didn't match their needs. As you can see from the first quote, the clinic was overcapacitated and the participant had to wait, but they never heard anything from the clinic, and they were just left thinking that they'd been forgotten about. Whereas the second quote shows the dismissive attitude and gaslighting from healthcare professionals when they did eventually access the long COVID clinics. Stakeholders and patient advisory group meetings highlighted the inequality in long COVID clinics across England. Some are better equipped to manage long COVID, and not all have the services that some of the bigger long COVID clinics do. Symptoms were emotionally distressing for participants, as one person describes in the first quote. They felt like they were slowly dying, and this still impacts them today. But it's not just symptoms that are emotionally distressing for participants, it's also participants' healthcare interactions, which were major stressors for participants, causing them emotional distress. For example, some participants found it difficult to talk about psychological symptoms of COVID-19. They felt like they would be discredited, for instance, or some felt that they had to focus on their physical symptoms in order to receive good care and support. Others needed validation from other people close to them to encourage them to seek help for their psychological symptoms. However, not all people have trusted others who they can discuss their symptoms with in a safe space. Stigma within communities means that some people may hide their symptoms and be left to suffer in silence and therefore not seek healthcare support. As you can see from the first quote, some participants did receive acknowledgement of their long COVID symptoms, but there was still no support or treatment for them. Although participants were aware of the lack of knowledge and support that general practitioners could offer them, what was particularly distressing for them is they felt that they just did not want to learn about long COVID or how they could support them. And some participants felt just in general that they're not able to support people with mental health difficulties. Also important are wider systems of support and social networks such as friends, family, faith and religious organisations, support groups, charity, social media. As you can see from the first quote, a close family member was pivotal to supporting them through their long COVID journey, pulling them through the darkest times of their life. These types of support can be crucial in providing practical, informational and emotional support. However, as you can see in the second quote on the screen, not all people have close social circles who they trust and provide a safe space. Lack of understanding, especially in relation to mental health, exists in some communities, which means people have to hide their symptoms. Role of others is important, as there is stigma within people's communities can prevent them from seeking healthcare support and talking about symptoms. As you can see from the third quote, one participant just doesn't want to connect their symptoms of COVID. Overall, most participants reported challenges accessing healthcare, and they frequently reported negative experiences with healthcare professionals, such as being uninterested, unknowledgeable, gaslighting, dismissive attitudes, etc. But some participants did report good relationships with their healthcare provider, and these were encounters where validation and acknowledgement were provided, and participants felt that they were listened to. Some participants from more privileged backgrounds were able to purchase private healthcare for support for long COVID, or they were able to better advocate for their NHS referral. These people were people mainly from healthcare backgrounds, but most participants had to end up sort of cobbling together their own care and treatment plan or self-management program to support their long COVID journeys. So what I've described so far is the participants generally experience problems accessing healthcare support, so difficulty getting recognition, psychologizing, gaslighting from healthcare providers. Generally, just getting help for long COVID is difficult. However, people from racialized minorities face additional layers of adversity. So there's this extra layer of disappointment on top of the problems that we've already discussed. So our participants talked about how they suspected racism in their healthcare encounters, and their suspect for racism might be due to their past experiences of racism in healthcare interactions. Some people felt that it was quite difficult to pinpoint whether they had been racially discriminated against, and they typically made comparisons to white patients to be able to cite their examples of racial discrimination. Here are some examples of suspected racial discrimination in healthcare encounters from our participants. So the first quote talks about how previous health encounters can shape future help-seeking behaviours. And the second quote talks about how symptoms aren't taken as serious if you're from an ethnic minority background. They talk about how it takes a greater level of suffering for healthcare professionals to recognise that there's something even wrong. Whereas the third quote talks about how the participant feels like they're treated more harshly compared to a white participant. To conclude, our findings from the High Cove studies resonate with previous long COVID studies. However, the challenge now is to take action to improve people's healthcare interactions and their long COVID management.
Thank you. Great, Nina. I believe Nina may be with us later for questions. So thank you very much for that. I'll move on quickly to introduce Dr. Alice Nightingale from the SPLAT study at the Keele University. Over to you. I hope you're here. Yes.
Yeah, I'm here. Hi.
I will, sorry, I might rudely interrupt at 9 minutes and say 1 minute left, if that's okay.
No, that's fine. Absolutely fine.
Thank you. Please.
Great.
Go ahead.
Hi. Thanks. Hi, everyone. It's great to be here and share some of the findings that we've had from our research and connect with you all. So thanks so much for the opportunity. I'm Alice. I'm one of the qualitative researchers working on the Long COVID in Children project at Keele University, and I'm also joined by Vicky, who's one of our academic GPs on the research team, and she'll be around for questions later. So today I'm going to talk a little bit about our Long COVID project and share some of our findings about the meaning and importance of Long COVID diagnoses from the perspectives of young people with Long COVID, their families and professionals involved with their care. Can I have the next slide, please? Thanks. The SPLAT-19 project is currently running at Keele University, investigating the symptom patterns and life with Long COVID in children and young people. And this project really aims to capture what Long COVID looks like for children and young people and explore the impact of Long COVID on young people and their families. So in terms of the symptoms, but also including personal, family, kind of social and educational effects. So there's several components to the project. We've done a systematic review of the literature about how Long COVID affects children and young people. We've got a cohort study that's currently in progress. But I'm going to focus on the qualitative study today, which has explored the lived experiences of young people with Long COVID and the impact that Long COVID has on their lives and the lives of their families. Next slide, please. So to do this, we carried out interviews with children and young people with Long COVID. Participants were identified from the SPLAT-19 cohort, and all of them experienced persistent symptoms for more than 4 weeks after their initial COVID infection. Out of 67 invitations, 4 people came to interview, all female, aged between 10 and 17, 3 of whom came with a parent, which was really great because it allowed us to gain some insight into their experiences as well and look at how Long COVID impacted the family as a whole. We also ran 2 focus groups with professionals who work with young people and who had experience of working with young people with Long COVID. And we asked them to talk about their experience of working with young people with Long COVID, what support, what information or training they'd been given, and what their thoughts were about what had helped younger people with Long COVID. So we had quite a mix of professions in the sessions, including GP, we had paediatric consultants who both worked in Long COVID services, physiotherapists who worked in Long COVID services, a mental health nurse consultant, and a primary school teacher. So we recorded and we transcribed these sessions, and then we analysed the transcripts thematically, drawing on the constant comparative method, where you analyse the transcript separately and then you map the findings onto one another so that we can really make comparisons between the experiences of the different groups. Next slide, please. So I'll quickly run through the study findings. In addition to findings about the impact of Long COVID on young people, we saw that there was a general lack of knowledge and understanding about Long COVID in children in the public and sometimes in healthcare professionals, which affected people with Long COVID and had a really big impact on parents. And actually, this is something we've been doing quite a lot of work around recently, particularly with schools. Participants mentioned stigma around Long COVID and described how this made it difficult for them to talk to other people about their experiences. And we saw that though there are Long COVID services in place for children, they can be difficult to access. A lot of the discussion included references to Long COVID diagnoses, particularly whether the participants have been given a formal diagnosis of Long COVID by their doctor or not, and what that meant to them. And while diagnoses were mentioned quite a lot in the interviews and the focus groups, the young people and their families seemed to view the Long COVID diagnosis very differently to the way that the professionals were talking about it. And that's really what we're here to focus on today. Next slide, please. So when young people or their parents mentioned Long COVID diagnoses, they talked about how important that diagnosis was for them, kind of clinically, but also socially and more broadly. And all participants who have pursued medical support for Long COVID kind of talked about the difficulties with getting a diagnosis for Long COVID. Many of them had struggled to get a diagnosis at all, and kind of said that the GPs that they talked to didn't know much about Long COVID and hadn't felt able to give them a diagnosis or offer much advice about what to do. And that lack of diagnosis came with quite a strong sense of uncertainty about what it meant to have Long COVID, and that affected the children and their family, and it had wider ramifications for them. So no diagnosis or referral meant that it was difficult to access support. But not only in the NHS but at school. And one parent kind of told us about how without a diagnosis, school wouldn't allow any timetable changes, wouldn't provide any support. And they'd said that they'd had to pursue private healthcare purely to get a long COVID diagnosis, just so that the school would help them. And then in contrast, when participants talked about receiving that diagnosis or self-identifying with descriptions of long COVID in children, they were really positive, and they talked about gaining a sense of understanding and validation of their experiences, and it's supporting them in being able to seek kind of medical or non-medical support. Next slide, please. So on the other hand, the professionals, particularly healthcare professionals, talked about their perception that a diagnosis was a medical burden for the patients, and kind of they stressed their desire to demedicalize the situation for patients and families by not labeling that illness. Coupled to this, they described how they felt that like a diagnosis was relatively unimportant for treatment because they were treating patients according to their symptoms and their needs rather than due to their diagnosis itself. And from their perspective, patients would receive that care that they needed, whether they had that formal diagnosis of long COVID or not. But actually, they also talked quite a lot about struggle for funding for children's services, and kind of talked about how this also influenced their decision making when it came to giving diagnoses. And when they talked about making diagnoses, healthcare professionals described very long waiting lists for children's services and how those long waiting lists can prevent children accessing help that they need. And one physio in the focus group described how they sometimes gave a diagnosis of long COVID and referred to long COVID services because those long COVID services had much shorter waiting lists, and that enabled young people to access support for their symptoms as soon as possible. So she described really using diagnosis strategically to ensure that children could access necessary care. Next slide, please. So we know that patients and healthcare professionals use diagnoses differently. In medicine, diagnoses are often used by clinicians as part of a decision-making process, as part of interpreting information from patient results and kind of that management process. And we know that for patients, diagnoses can be really important in a social sense, and they can provide legitimacy and allocate responsibility of care. With long COVID being relatively new and the current healthcare situation, it seems to have affected how people are giving and using those diagnoses and what a long COVID diagnosis really means. And there seems to be some uncertainty though about a long COVID diagnosis, and associated with that kind of general lack of understanding or lack of awareness about long COVID. And that's kind of what we've seen here. So obviously the study had a really small sample size, and these are just the experiences of the people that we interviewed, but I think it's really highlighted very big differences in the way that young people and their families and their healthcare professionals are approaching long COVID diagnoses. And far from being kind of the medical burden that healthcare professionals suggested, children and young people were describing how a long COVID diagnosis was a benefit to them and it really helped them. And we can see how it helped them kind of make sense of their experiences and what they were feeling, but also to help them and their families access support from school and clinical settings. And then the broader effect that that has on their well-being. We also saw how in cases of limited funding and long waiting lists, how diagnosis can be used almost politically to act as a gateway to accessing support. And these are findings that we're currently exploring in greater detail as we kind of write up our findings for publication, that we've been working on when we've been building on engagement work that we've been doing with schools. Next slide, please.
1 minute, Alice, thanks.
Thanks. I'm done, really. That was a quick summary of our findings. Thanks again for inviting us here and listening to our presentation. Vicky and I will hear questions. Yeah, thank you.
Thank you so much. If you can stay with us for the questions, that's amazing, and amazing timekeeping. Thank you so much. So back in June, we had a health inequalities and long COVID workshop with presentations from several studies. And the next presentation by Dr. Sarah Bass from the University of Leeds, from the University of York, and Dr. Ghazala Mer from the University of Leeds is going to do the very difficult job of summarizing the main themes from that workshop in the next 10 minutes. So over to you, Sarah and Ghazala. Thank you.
Thank you, Nisreen. Yes, as Nisreen said, we'll be presenting the key themes from our workshop on long COVID and health inequalities. So the next slide, please. So just a bit of background to the workshop. The workshop was run by the Qualitative Long-COVID network, which involves around more than 80 academics that are working on qualitative long-COVID projects across the UK. It took place on the 19th of June in person at UCL and hybrid as well. There were presentations from 6 research project teams focused on long COVID in relation to health inequalities and presenting their project findings. So the convalescence study, which I'm part of, which is a longitudinal qualitative study exploring experiences of long COVID. The health talks, which is various kind of different studies who are actually presenting as part of this event today in session 3. HiCov, which Nina has presented today. Locomotion, which Ghazala is part of and will discuss today as well. The Split 19 study, again, which Alice has presented on today. And then finally, the Stimulate ICP study, which Nisreen is part of. And we also had one PPI representative from the convalescence study who shared their lived experiences of long COVID, and finally 3 presentations from long COVID charities, which was long COVID SOS, long COVID kids, and long COVID support in terms of the support they provide to people with long COVID. And obviously all of these findings are based around qualitative research, including in-depth interviews and co-production methods. So I guess the lived experiences really inform the findings of each of these studies. Next slide, please. So there were kind of a number of key themes from the workshop, many of which have been covered today through the presentations. And what was central to this, the central kind of theme was obviously around inequalities and the intersecting experiences of people. For example, how people's ethnic, gendered, and socioeconomic circumstances intersect to shape their experiences of long COVID and accessing healthcare experiences. Obviously, today we've heard about experiences around kind of age and experiences of racism when accessing the healthcare systems through the earlier presentations. Gatekeeping was another key theme which the PPI representative talked about. So this can be in relation to kind of GPs or primary care being gatekeepers to further secondary care services or long COVID clinics, the difficulties people face in accessing welfare benefits, how obviously long COVID and COVID itself is politicized, which Margaret mentioned today, and how people actually feel really exhausted in navigating the systems to receive healthcare. Another theme was around stigma, which again has been discussed today, and experiences of mistrust and discrimination, which in turn kind of shape the experiences of people who interact with healthcare services. There was real kind of this idea that there's an importance of getting diagnosis and long COVID being recognised by healthcare professionals, and how the positive experience of having validation is really important to people with long COVID, that they're believed and not stigmatised for what they're experiencing. We also found we discussed various barriers to accessing and engaging with healthcare services. And finally, we also kind of discussed of how long COVID can actually help us to learn about other long-term conditions and illnesses that may previously been dismissed by society or healthcare professionals, and how much potential we actually have from kind of learning from long COVID and making sure we get it right this time to support people that have long COVID, and how this practice can be shared to support people with other similar kind of long-term conditions. And then finally, we also discussed the implications for practice, which Ghazala will present on now in relation to the study that she works on. So over to you, Ghazala.
Thanks very much. Could we have the next slide? There's some resources. Yeah, some resources that I think will go out with the slides that people can look at. So as Sarah said, I'm working on the locomotion study, and what we've tried to do is as you know, there's been so many issues that have been highlighted in terms of barriers to referral, access, and treatment. And what we've tried to do within locomotion is to try and work out what good practice would look like, what could actually move the discussion on, and to explore what could be done by people working in long COVID clinics, by healthcare professionals more generally, and in other sectors. And we focused in that study on people who have long COVID from deprived, ethnic minority, homeless, or have a disability, people from those backgrounds, most of whom haven't attended clinics. But we've also spoken to people working in clinics and to experts on health inequalities and long COVID. And we've come up with a number of ideas about what could be done in terms of referral and access, for example. So first of all, actually making these inequities visible is really important. To access data, use data, try and find out who is not using services, who is not getting the kind of support that they need, so that services can be prioritised and tailored to meet those needs. In terms of GPs acting as a barrier, some clinics have been targeting GPs for training in the symptoms of long COVID, targeting GPs in deprived areas who may not be referring patients at all, also involving third sector groups, advocacy groups in the process of LC referrals, long COVID referrals, and helping people to navigate the support that's out there. People have mentioned low awareness of symptoms. This is one of the issues particularly affecting minority ethnic communities who, in the larger studies, have been showed when we look at symptoms, they are overrepresented in long COVID. But if we look at Office for National Statistics data where self-report is the key mechanism, they're underrepresented. So actually increasing awareness amongst particular communities, also amongst occupational health and human resources influencers is really important. And then in terms of the waiting times for long COVID clinic support, some clinics have been using that time to pass on information, to provide educational opportunities, to signpost people to peer support and other support whilst they're waiting for specialist care. Also offering clinics in diverse sites so that people are not disadvantaged by where they are. There's another thing at the bottom that you might not be able to see, which talks about the financial and capacity barriers. Offering people a choice of virtual, face-to-face or home visits can really help, where the capacity to actually attend may be an issue, or digital exclusion can be an issue. Some clinics are working with local authorities to provide IT support and equipment, for example, and also signposting people to support for welfare benefits help, housing help, even to food banks. Next slide, please. In terms of treatment and management, a key issue that seems to be coming out of the data is the need for multidisciplinary and multi-sector teams to avoid the kind of issues that have been raised about people being referred to multiple clinics, all of them with long waiting lists, that what people really need is holistic support and tailored care pathways, and a multidisciplinary team working across different sectors can reduce the impact of referral to multiple clinics. And this particularly affects people with existing levels of ill health, high levels of ill health. And it also helps to balance the new patients with long COVID with the existing cohort. So how resources are used across those different groups is really important. And it also helps with the uncertainties about comorbidity and how to manage changing needs, because we know in long COVID, self-management can be an issue when needs keep changing. A number of clinics are trying to move beyond monitoring, and a number of support services are trying to do that, to be adapting to care as the research develops, and they're taking kind of trial and error approach to have an evolving service that establish new pathways as new needs are recognised. Some GPs are liaising with employers to support return to work, which can be much more effective than people advocating for themselves. And there are some examples of employer support networks, particularly within the NHS, where many staff have had long COVID. The problem is actually the consistency. Next slide, please. So the next steps for our research collaboration across the different studies is really to continue to join up the studies and the findings so that we can have more impact and a higher profile, and also linking the evidence that we've gathered with the stories about how this actually impacts on people's individual lives. also linking the quantitative and qualitative work. In a couple of the studies, a healthcare tool is being developed. In our locomotion study, we're trying to share good practice example for inclusive services across different clinics and across different services. Ultimately, the goal is to influence policy and practice. We know that COVID is still circulating. Long COVID is still a hugely significant issue. So it's really important that we continue to focus on what needs to be done. And I'll just pass over to Sarah, I think, for the next slide. There's our contacts on the next slide. If anybody would like to get in touch and get in touch about what we've presented today, but passing back to Sarah for the interactive. I think it's Nisreen or Sarah dealing with the interactive.
Thank you, Ghazala. I think we have a few minutes for questions before the interactive session, so it'll be great for the speakers to put their cameras on if they're still here, and we can have a few minutes of discussion and question. Now, please do put your questions in the chat for our speakers for over the next few minutes, and I'll read them out. If I may start while you do that with a question to all the speakers, really, just if any of you have any reflections. It seems a big theme of the inequalities is kind of that route through diagnosis and recognition through clinical care into things like employment, or for kids, indeed, into things like education and school. And then when that route, there are challenges along that route, and there are inequalities and stigmas, and then that has far wider implication than the actual kind of clinical care for people. So I don't know if anybody would like to reflect a bit more on that, because that to me came out as a very strong theme throughout all of the presentations.
I think just the point about multi-sector collaboration is really important. Making sure that we're not just looking at healthcare, but the determinants of health as well as part of this in terms of the solutions in particular.
Thank you. Victoria, do you have any reflections on this?
Thank you. It came through really strongly that navigating that process seems to be very dependent on the individual professionals that you encounter along the way. So it's really great to hear that work's going on now to try and sort of get people to have a bit more joined up thinking. The other thing, we've been doing a lot of work with schools, and this is not really known about amongst children and young people unless you've got a direct lived experience of long COVID in the family. A lot of the children we spoke to, these were primary and secondary schools, didn't know what it was, didn't know it was a thing, didn't know how to interact with their peers. So yeah, there's still a lot of challenges ahead, I think.
Thank you. Margaret?
Yeah, I just wanted to make the point that there are a lot of disadvantaged and underprivileged people who find it difficult to access healthcare and advocate for themselves in a lot of diseases. But I think what our case studies showed is it doesn't matter how educated or privileged you are, you can still be victimized by the power imbalance of doctors who simply don't believe you and will use their power. I mean, that the natural extension of gaslighting is that you will be cast as having a mental illness, because sanity or insanity is a matter of who believes what. And if everyone around you is consolidated on the belief that your illness is made up, then you look like the one who is psychotic or is having a mental health challenge. And I think we really need to address the power imbalances in medicine. And why do so many doctors believe in fabricated illnesses? Genuine fabricated illness is such a rare thing that most doctors will never ever encounter it in their entire career. So why is it that time and time again patients are having to say, are saying things like, oh, this doctor believed me and that's a bonus? Why is it a bonus that a doctor or a healthcare professional believes what you're saying? Why is that not just a given? Why are we teaching our doctors to disbelieve patients, and in particular certain types of patients more so than others? I think NHS England has really got to grapple with that, because I think we can advocate and fight as much as we want, but they have the power and they need to use it.
Thank you, Margaret. Really strong reflections there. And I have to say, all throughout my experience with long COVID, my personal and the people around me, what I've encountered over and over again is people trying not to label themselves with long COVID because it's such a disadvantage to have it, rather than the other way around, where you trying to, malingering and fabrication, saying I've got it. It's always been like people try and dissociate from it as much as they can until they just can't do that anymore. So yes, absolutely agree with you. We need to change that sort of narrative. Mo, have you got a question? You've got your hands raised. Is that Mo? Am I pronouncing the name correctly? Yeah, you're muted.
Yes, thank you.
Thank you.
Yes, right. Thanks for the presentation. Actually, I'm following on from what Margaret just said. You see, most doctors consider it hypochondriac when you go to say, oh, you have this, you have that, or when a child is not acting in what is expected, they think, oh, he's playing up. The question here is this, it's not about, you see, although Margaret mentioned about the GPs, I don't think it's the GP. What guidance do the GP receive is important, because GP doesn't formulate guidance by themselves. They receive guidance from NHS Central, who tell them what to look for and what not to look for. I was a member of the Long-COVID program board, and in one of our sessions, I think one of the clinicians was saying that what happened is that they are now trying to what they call do a reverse something by eliminating other conditions that could be causing the tiredness or the symptoms, which I think, okay, it's okay in a way, but it's wrong. See, in the first place, has the NHS admitted or accepted or recognized long COVID as a condition? Until the NHS recognizes that symptom as a condition, as a long-term condition, GPs are likely to do less, because GPs do not act on their own independence. They act on the guidance provided by the NHS. So when I asked that question in the chat, that has your findings been actually passed on to the NHS as a recommendation? Until that is done, nothing's going to happen. I can assure you that, because anyone else will be classed as having, psychological illness. No, children. I was in the meeting last week with a pediatrician who was suggesting. Then I asked him, how do you differentiate COVID symptoms from psychological issues? I said, because any child that you present at the clinic, simply they are not looked after as treating long COVID. They are actually being treated by psychologists. As at the Evelina, for instance, they don't have any specialist pediatrician on long COVID. All they have, they're actually manned by psychologists and psychotherapists. So if
thank you, Mo. Thank you, Mo. Sorry, I don't mean to interrupt, but yeah, we kind of have to move on. There's also a very important question, but I think just quickly to say there is obviously long COVID is recognized and there are clinical guidance around it, but the issue is there might be more specificity. And I think what you said is really important. It's a call for all of us involved in long COVID inequalities research to make this extra effort to share and communicate our findings with the clinical team in the NHS, but even wider, and keep trying to do that. So thank you for that. I want to very quickly, I'm a bit over time, but I want to very quickly say there's a question from Roxanne saying, has there been specific research in Eastern European population groups? Anybody from the speakers know? Obviously they would be included in kind of general research, but I don't know if you know of any specific research on long COVID in that group. Anybody? I'm not aware of. So that's an important thing to consider indeed, for particularly some areas in the UK. I mean, particularly where I am in Southampton, that we have a big minority from Eastern European populations. Thank you. So I think I'm going to wrap up the questions, and there'll be more chance to discuss things in the group session, the group breakout. So I'm handing over to Sarah now to describe what happens next. Thank you, Sarah.
Thanks, Nisreen. So next, the groups are we're gonna break out for 15 minutes. And what we want you to discuss in your groups is based on today's presentation and discussions. What do you think are the key practical steps and commitments needed to address long COVID health inequalities, and how can these be achieved in your own practice? So you can draw on your own practice, your research, or even your lived experiences of long COVID to provide these kind of recommendations. In the chat, Louise has just put in the Jamboard link. So what you can do is, when you discuss this in your groups, put your ideas on the Jamboard, and then we'll reconvene. And if you nominate one person to share one of your kind of key practical steps, and then we'll come back and talk about those and read the ideas on the Jamboard as well.
Thank you, Sarah. Louise has put the link into chat. We have just shared the breakout room. So the breakout rooms, the links will go into chat as well. Very, very simply, I know most of us are familiar with Teams now, but if it's not your home, you will need to find your name on the list. It's alphabetical, so A and B, you're staying in the main room here with Donna. If your surname ends with a C to an H-ish, you're likely to be in room 1, but H to L, you may be in room 2. M to N, you are in room 3. That's your surname. If your surname starts with an O or an S-ish, you're in room 5, but some of the S's with the T's will be in room 4, and then the S to the T's you'll be in room 5, and the rest of the T's and the W's room 6. I'm sorry to reduce you to your surname, but it's probably the easiest way. So in a moment, we'll invite you to go onto those links, and we'll just quickly circulate to make sure that everything's working. You have 15 minutes, so that will take us to, unless Nisreen wants to change it, but that takes us through to 10:20. So I think we are ready to go. We're here in the main room. If you've got questions, just pop back, so you can toggle between the two. Don't worry, if you fall out of the system, you can just come back in by clicking on that main link on the invitation. So don't worry, you will be able to come back in. Is everyone clear?
Thank you. Yes, and please don't forget to nominate someone to feed back in the 5 minutes we have, because it's important to have those main messages at the end. Thank you. So nominate someone from your group to feed back. Thanks.
Perfect. So we'll see you back here in just under 15 minutes.
How do you join the room?
So in the chat, there is a series of links. So Mo, if you find your name, it will tell you which room that you're in, and you'll click on that link for the breakout room. Can you see it in the chat, Mo?
Yeah, okay.
So, and don't worry, if you just pick a room, if you can't find where your name is, just pick one of those rooms and it will take you straight into that breakout room.
Yeah, but I gone, but it's not going.
So,
I see the breakout room. I click on it, but nothing happens.
So it's not taking you out.
Just stay in this one then, Mo. There'll be people in here that are having a chat.
Yeah, I've got nothing in my chat, nothing at all, no links.
I think people having difficulty is a good suggestion to stay here, and we'll still have the discussion here.
Perfect. We'll jump into the other rooms. See you in a moment.
Cheers.
Right. We've got a big group here, haven't we? So I think the question is, is for everybody really, and I'm not trying to chair this one as a group thing, but we need to nominate someone to give the message about what do you think are the key practical steps and commitments needed to address long COVID health inequalities, and how can this be achieved in your own practice? Anybody wants to talk about this?
I think a good point from which made me think from what someone said in the chat, and Nisreen, what you picked up on just before we broke out about the, for example, the Eastern European groups. I think the first important point is to understand your population. So understand kind of the groups. You know, we know that across the UK and across England, there's different prevalence of different groups within the population, and some areas are more likely to have high amounts of certain minority groups. But I think, so it's important to understand that and kind of try to tailor your approach to the groups in your population. But at the same time, it's also important to remember that just because a majority of your patients or your population might be of a certain demographic or of a certain group, I think it's always important to remember that even if it's just one person that's of a particular demographic and they're not in the majority, it's still kind of important to make sure that they're not being forgotten and yeah, they're catered for. So I think that's something to consider.
I completely agree. Sorry, Sarah.
I've added it to the Jamboard. I'll just type that idea.
Yeah, I can see you're typing on the Jamboard. That's great.
Yeah.
I think for us as well, just reflecting, because it's about your own practice. So if we're doing research, I think we need to make this extra effort of engaging about the findings with service providers, and challenging some of kind of the norms or the practices, challenging them with research, with evidence, and trying to kind of reach out a bit more. I think we need to do that more and better, because and quicker, because this is a problem that we have now. So yeah, thank you, Sarah. I think it's we need to brush kind of up our game in terms of engagement, because I think, Mo, you've made a very good point about how we're engaging, and I suppose activities like this help, but how else we need to get together and say how else can we get those findings into that kind of everyday kind of practitioner, really. Yeah.
Yeah, in our convalescence study, we're also interviewing 15 healthcare professionals that are involved in long-COVID services in Bradford. So we're really trying to, when we write up the findings, so we're looking at how the services develop over time, really target kind of the NHS and also the local kind of Bradford services for long COVID. And what we found with our the 40 people from long COVID that got long COVID in Bradford, try to share those findings with them. So trying to, like, as Nisreen said, trying to kind of share research into practice. We're trying to do that over time.
Yeah, you see, what I'm thinking here is this: inequality exists because of lack of information. You see, most people are not aware of what long COVID is, and they may be experiencing the symptoms, but don't know how to relate it. So it is difficult for them to seek help. Unless, you see, general awareness, the NHS has to make it a policy to actually disseminate information regarding the illness. That way, people will be aware of it, and it should be available to people in maybe different languages, and targeting the communities, particularly, especially the minority groups, most of them through churches, through mosques, and so forth, because they are more likely, the community are more likely to listen to what their imam or preacher tells them. than what a government official tells them. Conspiracy theory, in brackets. You see, when you want to reach out to the communities, you reach out to them through their leader. In every ethnic minority group, they have a traditional or a natural person they actually look onto. Whatever that person tells them, they are likely to listen and accept it as a fact than when they receive a letter from the government telling them. Because I remember during the COVID infection itself, some communities were thinking that by going to take a vaccine, they were being injected with what they call tracking device. And they believed it. And hence, the uptake was very low until we suggest that, look, why not go to the community leaders and approach them? When they did, the uptake went up. So information dissemination in a particular and formal way to those communities will help. Because unless people are aware of it, they're not likely to seek help. That's my take. Thank you.
I think there are also hidden communities. So I'm a late diagnosed autistic woman. And when I go to the doctor, the fact that I do autistic masking means there's a mismatch between me, what I say, and what I present. Exactly. And it doesn't matter how hard I try, the doctor will still pick up on that mismatch. And they will go, there's something not right here. But when I say I'm autistic, they'll say I make eye contact and that I have empathy. So they'll think, oh, well, she's not autistic. There's something else going on here.
Exactly.
And just just to be listened to, and for my experience to be believed. And it's not that I've been signed off sick. I've been, I've lost my job, and the doctor sort of supported me in that, but not enough. Not enough. I needed an acceptance that my experience was real and not a feeling that I was constantly the gaslighting theme. So it's the fact just that the doctors don't always know when someone is in a minority.
Of course they don't.
Yeah.
That's a really great point, Annie. Do you think this is to do with stereotyping, isn't it? Like a bit of lazy stereotyping about what to expect. Yeah.
Yeah, I'm not from Big Bang Theory. I'm not, I'm a woman, I've got a child, I've been married, you know what I mean? So there's lots of stereotyping and lots of but I do think that I'm not sure, sorry, I'm going off track, but I'm not sure if there is evidence that autistic people are slightly more likely to get long COVID, but I think there might be evidence there, so that we, because there's a particular gene mutation, the MTFR, I'm getting it all wrong, and there's also the fact that the lived experience of someone who is constantly hypervigilant because of being a square peg in a round hole means that we're slightly more likely to be burnt out and be kind of easy pickings for a not fully functioning immune system. So therefore, we're just an important group that kind of sometimes, I don't know, maybe get missed out. Anyway, that's my, but the big thing that I think came through from this so much was that we need to be listened to, that we need to be understood, because the experience of long COVID is also difficult to communicate. My brain fog makes it very difficult for me to hold on the different ideas of the different. If I'm not got a pain in my side at the moment, I can't remember where it is,
That's correct.
So we have so many barriers, and if we see a different practitioner every time, then how can we start off from the bottom again, explaining everything? Whatever barriers we have, we will experience them again and again with a different practitioner. At least if we had one practitioner, we could learn them and they could learn us.
Yeah.
We didn't agree who would feed back. Is Annie? Are you? Sorry, you're happy to feed back. I think you raised some really important points, and I think the main other thing that we discussed was obviously which Mo raised, was the how does research reach practice, and how can research, we need to kind of increase our reach, but that bit about kind of you being hidden disadvantage, if you like, and then getting stereotypes as something else. That's a really powerful point.
Well, also, yeah, I mean, the only trouble is if I feedback is the brain fog. I may completely forget what we've said. So I kind of would rather not, but I just think.
Okay.
So one other thing occurred to me. God, it felt important. No, gone. Yeah, actually, no, it's the gaslighting. It's not until I got to that point that I said to Reese, God, I am in a minority. You know, I am actually, because I forget my disability because I'm constantly gaslighted that it's not a thing. So I forget it. It's like, oh no, it's not important. It's my long COVID's not important. My autism's not important. My, you know, sort of, it's not important. I'm overreacting. I'm, you know, I'm being.
Annie, we actually did some research on that, and that's a dimension that could be regarded as a dimension of stigma. We call it internalized, because you get told all the time that this is not real. Then you kind of think, well, is it not real? And there's some sort of psychological process. It's really important about, you know, if if society or the media or the people around you or, you know, telling you something and you kind of internalize that. And we found that they're very high levels. We did a big survey of like hundreds of people we had very high levels of internalized stigma, and that.
Yeah.
So, okay.
Just to let you know, people will start to join us in a moment.
Brilliant.
Sounds like you had a great conversation.
Group one?
You are, well, you're the main room. I think that was group one, but I will double check.
When I invite people to, or Sarah, do you want to do that, Sarah? Just like, I don't know what we call when you invite people to feedback, whether they'll recognize what room they're in.
Should we?
Nisreen, just to let you know, we merged rooms 2 and 3 and room 5 and 6. So we've only got 1, 2, 3. Oh, we've got main room 1, I think, is the room, and then room 2 and 3, room 4, and then room 5 and 6.
Amazing, thank you. Sarah, do you want to call for feedback?
Yeah.
Yeah.
So it's main room 1 and 2 together.
No, main room 1,
yep.
And then I think that, well, room 2 and 3 merged, room 4 was by themselves, and room 5 and 6 merged.
Okay.
We'll make it work.
We can ask anyone to volunteer first.
Absolutely.
So put anyone on the spot.
Absolutely. I think there's still a few on hold, but they'll be coming back. I'll just go and check room 4 and 5 and 6 are sorted. That was my room. I'll be back.
Thank you.
Thanks.
Just pop into there. Here we go.
So I hope people are coming back to the main room now, and I can see less people are on hold. So hopefully that's happening. Sarah, maybe Sarah, shall I feedback quickly on our room and then over to you? Okay, because we haven't got much time. We had a great discussion in our room, and we talked about how we need to make bigger, more concrete effort in research, because this is really about, you know, we had a couple of researchers in our room saying that, you know, how can this be achieved in your practice? We need to reach out to service people in the service and get the research that that was presented to them. The research is very clear about the stigma, stereotyping, inequalities, and we need to make a bigger effort of getting this research out to service providers so that they look at this evidence. And we also talked about stereotyping, about kind of you might be in a minority, in a disadvantaged community, we call hidden communities, and how that cannot be recognized in a consultation, and there might be stereotyping and assumptions about, you know, what community, you know, what you are, and actually that you know, that links to some of the, we didn't have time to touch, but some of the things I'm particularly interested in is intersectionality, how all your different identity dimensions intersect to create your experience, and how that can be really missed by you being stereotyped in one single identity dimension when you have a quick consultation. So over to you, Sarah.
Thank you. I think we also discussed the importance in terms of the next practical step of the NHS to raise awareness of what long COVID is, to engage with communities to get the message out. Does anybody else want to volunteer for any group to share their ideas?
I think Roxanne's.
So I was in group 5. We were talking basically about kind of patient expectations of long COVID clinics and how we know that they're all different, that they all have different staffing, and what would be really useful would be kind of an overall kind of glossary as to, or kind of guide as to, you know, this long COVID clinic is a rehab clinic, this one is diagnostics, these are the staff that are available, just to help kind of manage that expectation so that when you get in there, you're not going, oh, they've actually done nothing to help me, because maybe you'd expected something different, because it is a bit of a postcode lottery. We also talked about reaching out into the communities a little bit more. Anecdotally, we've seen a kind of a disproportionate amount of neurodiverse people coming into services, and actually that's kind of not come out in research just yet, but maybe targeting you know, diagnostic services, or targeting you know, the specialist support services, or linking in with the community you know, neurodiverse services, to make sure that those patients are coming through that perhaps wouldn't standardly visit their GP. And the same with, you know, some of the ethnic populations that we have. It's a different population in each county. In our county, it is Eastern European, and again, these are people that maybe standardly look for their communities, and we tend to get word of mouth referrals for people that you know, say, oh, my friend's been through the service, that maybe aren't aware of long COVID. So, you know, having that information in places of worship, in community centres, translated into their own language, making them aware that we have translators and things like that would be really helpful. I think that was pretty much it.
Thank you, Roxanne. That was some really good ideas to potentially take forward. We can take any ideas from one last person.
Everyone's being super polite and waiting for the other person to put their hand up.
Shall I pick a room?
Oh, here we go, Pamela.
Hi.
Hi, can you hear me? Hi.
Yeah, we talked a bit about using our community resources and widening out the links to involve key people within the community. So trying to find those people and then use that to increase symptom recognition, symptom knowledge in the wider or harder to reach parts of our community.
Yeah. So I just, you know, personally think that so I live in a community that is quite diverse, and you know, speaking to different people, I think that what are the expectations, how they perceive all of that, it's very different. So speaking to some people, they are like, okay, yes, I know I have long COVID, nothing can be done, so not even why bother. Why others just try to take every possible help here around. It's just that sometimes things seems a bit disjoint, or just to repeat yourself many times to different people and then get a little pieces of help here and there. But I think that probably if we try in some way to reduce the sort of a stigma, but also the try to help people with their expectation, we will have more people and more diverse people reaching out, because some people are still quite a bit between being scared and a bit between being hopeless of the situation, I guess.
Yeah. the real sense of like hopelessness come through, and the I think there was a paper by Kingston and Talent to talk about the hard and heavy work that people with long COVID are having to do, of both managing this kind of new illness, but then also navigating the services, which comes through. Thank you, Pamela.
Well, thank you, everybody. I think we need to hand back to Ruth now to close the session. I just want to say thank you to all the speakers, everybody who participated. It's been a great session. Thank you, Pen. And the breakout groups worked. Yay. I mean, this is amazing. We're back here and we're on time. So thank you. Over to you, Ruth.
Indeed, and I'm just going to echo your thanks. So I'd like to thank all of the speakers that Nisreen, you and Sarah managed to pull together. Just so many thought-provoking and for me things that I haven't really perhaps thought about in the depth that I need to. The idea, I have thought of some of these things, but the idea of patient groups being the only safe haven, you know, the far-reaching impact beyond simply having the condition, around the stigma and the gaslighting, overlaid with the issues that people are facing every day around racism or exclusion because of other differences. And the fact that the diagnosis is the key, it holds the key to so many things. I think, Pamela, you just talked about scared and hopeless, and that's really kind of wrapped it together, and that heavy and hard work that people with long COVID and indeed other long-term conditions have to do. Really thought-provoking. Massive thank you to all of our speakers, and also to Neil and to the NHS team for enabling this session to happen. So Nina and Joe, thank you for inviting Pen to be involved in this as the kind of the coordination. All of the resources will go up onto our website, and we will get that up in the next day or so. So you'll be able to go there and have a look, and we'll send the link out to you so you don't have to hunt around. A quick mention, unfortunately, we heard very recently that our session 2 speakers are not able to join us today. So we are not reconvening at 11, I think it was, we were due to convene, but we do have a full day for the afternoon starting at 1:30. So with every cloud, there is a silver lining. So I gift back to you some time today if you are planning to join us through the whole session. But please be ready to join us at session 3 at 1:30 because we are full on from 1:30 through to the end of the day. So that's me for now. We'll be here if you need us. And thank you again to all of you for joining us, and particularly to our speakers. Thank you.